still we have a couple of patients. So anyway, I'll be dealing with the how we have initiated the ventilatory support, and what all things we have to take care, like the PPE, all these things. So I'll start with my first slide. So this is just a brief introduction. We all know that COVID-19 is a new strain of coronavirus, which has a close resemblance to SARS, which was identified maybe like 2018, 17. It was quite a pandemic then also, but not like as what we are facing now in our present situation. So it's said that as per the studies conducted in Wuhan, it is said that it requires around like 14% of the patient requires hospitalization, and among that, the 5% will be they require ICU admission. In that 5%, the 3% are moving on for intubation also. So that's what the studies which they have conducted in Wuhan and in USA, they have said that most of the patients, though this like a common flu, they say it's like a common flu, but no, like around 14% of them are requiring hospitalization, and some of them are, it's getting critical also, we know that. So some of the known facts about the COVID, its incubation period is around 2 to 14 days after exposure, that is average 5 days as per WHO. Usually in ER, they are presented as directly with severe pneumonia. And the symptoms of pneumonia, we all know that it's basically with cough, tachypnea, tachycardic, and they'll be having a sore throat. These all are the classic presentation, and probably most of them, they are actually coming to the ER. What we have seen so far the trend is, it's like more or less it's towards when they are getting serious only, they actually really they are coming up to the ER. So it's like they have already quite worsened, I have to say. The C-reactive protein appears to be a track with the disease severity and the prognosis. The initially when they are admitted to the ER, the CRP is being checked so that they can identify the how far the disease progress have gone. The critical patients are found to be affected with cardiac failure, respiratory failure, and acute kidney injury, sepsis, along with ARDS. So this is the worst stage actually. And patients with comorbid conditions and older age are found to be at high risk for mortalities associated with COVID-19. We all know that it's been said that so far the comorbidities, those patients who are having higher comorbid conditions are said to be having higher mortality rate. So in my presentation, I'll be dealing with two patients, which is one of the patients is who is a younger patient and younger adult, and I'll be dealing with an elderly man also. So how these patients have been affected and how we have initiated the mechanical ventilation, all these things I'll be discussing. So moving on to the first case. This was a 27-year-old female. She presented to the ER with cough, fever, and sore throat for past 5 days. So she actually came on 9th of March, which I have to say the COVID situation was not very worse. It was bad, but it was not very worse during those days in back in our place in UAE. So she had no known comorbidities, no travel history was there was no close contact with the COVID patients as per her history when we took the history. But anyway, we had sent the COVID-19 screening because that was prevalent still, so we had to rule it out. So COVID-19 screening sample was sent. So the initial management, she was sent to the high dependency ward from the ER, and her saturation was around 92% with a heart rate of 78 and a rate of 24 and BP over 130 over 80. And she was connected to the nasal cannula because her saturation was still like 92%. So we had to connect her to the nasal cannula with 4 liters of oxygen. But unfortunately, there was no improvement. So we had to follow with NRBM. Within 2 to 3 hours, she was shifted to high concentration mask, or the NRBM, with 50 liters of oxygen. The radiological findings when she was shifted to the ward, we had taken the X-ray. It showed bilateral patchy pneumonic infiltrates in the lower zones. And the blood gases had also shown mild hypoxemia with a normal pH, I have to say. So the X-ray findings was this. If you could appreciate I'm sorry about the picture because it's not very clear. You can see the lower zones are quite hazy with opacities, and it was this was a first X-ray which was taken during her admission. So just keep this in mind because we will be seeing even worse further. So this was an initial X-ray. So with this drop anyway, she was getting worse. As I said, she was getting worse progressively. Like her distress was increasing. She was using the use of accessory muscles, and her saturation was not picking up even with high concentration of a high concentration mask of 15 liters. So we were under pressure whether we have to intubate because she was completely conscious and oriented actually. So within 12 hours of admission, patient was worsening. So I have to say the tachycardic was there. The saturation was like 85 to 85, 88% hardly, and BP was like 110/80, and an ABG was done during then, which showed this was the one I mentioned. This was ABG which we had taken during this events, and it showed PO2 of 50, which you can see that appreciate that there is no other abnormalities. It's just the hypoxemia. So the decision of intubation was still pending. So we had to intubate her because we didn't want to worse. So as a first rule for ARDS or like in SARS or in COVID, it said that the intubation should be decision of intubation should not be delayed. That's what they say. So we had to straight away intubate. We had to intubate her. But I'll just mention during this process when we had intubated her, the result of COVID was not out. We had sent the sample, but the result was not yet out because during within like as I said within 12 hours only she had worsened, and we got the report like after 12 hours because during that time the report usually it was taking like 12 or almost 12 hours for the final report. So but anyway, when we intubated her, we had taken all kind of precautions, airborne and droplet precautions was taken because still she was under query because she has because her X-ray explained, and rest of all other reports was like they all we all were thinking that probably this could be a reason. So she was electively intubated, and it was followed by a rapid sequence intubation. She was adequately sedated, and neuromuscular blockades was given. Intubation was uneventful. And so I will just tell you briefly about the PPE that we had used. So ideally, what in our hospital, what we are practicing right now is we are placing a yellow gown, and on top of that, we are wearing the hazmat suit. So we all will be familiar with the hazmat suits. So that is the white color dress which we are seeing right now. And maybe those who have experience with the COVID patients, you will be having a greater idea. So along with that, we had placed the N95 mask, and here we have a practice of keeping along with the N95 mask, we are placing a surgical mask also along with the N95 mask, so that we will have a quite a complete protection, as they say. And then we have the face shield, the goggles, the gloves. It's like you can use it as much as you want, because we are having a contact with their droplets. So we used like three gloves almost, because the last glove which we are wearing, we will be removing it inside the patient's room itself. Like once we are done with the patient, we are removing the first glove from the room itself, and then only we'll be coming out, because that's the glove which is already infected with the patient. And we are placing the shoe covers also. So the process of intubation was uneventful, and they were preferring only least number of people. So ideally, there were only me. I mean, the RT, the doctor, the anesthetist, the nurse, and the nursing team leader also was there in order to get the drugs and all these things. So they preferred only least number of people, because after all, we have you those who are getting in for the procedure, they are supposed to wear all these kinds of PPE. So we were preferring only limited number of people in. And during the process of pre-oxygenation during intubation, the bacterial filters was used, which was placed between the the mask and the amber bag, so that we can prevent any kind of infection, or any kind of the droplet infections. So after the procedure, like after we had the intubation was completed, when we then the time when we came out later, it was found that from the report that she was already COVID-19 positive. So the result had come by now, but anyway, we had prevented ourselves from exposure, because we were wearing all kind of PPE. So that was the problem of exposure was out of question now. The initial blood gas, so we had intubated her. The initial blood gas showed severe hypoxemia, because by the time she was really worse, it was severe hypoxemia with a PF ratio of 120. So you can say that it's like moderate to severe ARDS already. And we had followed all the ICU ventilation protocols. That is, we initiated her with a pressure control mode of ventilation, and the pressure control was set according to the target tidal volume. What we were thinking, like, because it's basically ARDS, so the ideal tidal volume will be 4 to 6 ml per kg. And higher PEEP strategy was also followed. So since her X-ray was suggestive of ARDS, and because of her, in view of her hypoxemia, we had initiated with a PEEP of 10. Actually, directly when she was intubated, we started with a PEEP of 10. But since the ABG was in the ABG, again the saturation was like the PO2 was still on the lower side, so we had to titrate it, like we had increased it up to 14 centimeters of water. So the peep what initially what we had initiated was only 10, and then we progressively we had titrated it, and we made it at a level of 14. Actually, I just made a mistake of that. This is 14 actually. I'm sorry for that. And the plateau pressures, of course, was we tried to maintain it less than 30 centimeters. However, we had achieved it somehow with the help of we were titrating it all along with the tidal volume. Then we were just playing with the ventilators, and finally we had achieved plateau pressure less than 30. The important thing, like, was that the good thing was that her BP was more or less stable. She was not hypotensive or anything, in spite of the high peep. She was not hypotensive, so that was a good thing. So she was not started on any inotropes or anything. So basically you can understand that she was a healthy individual. She was a healthy individual, and so there was no problem regarding the any inotropes or anything. And the saturation was initially, I have to say, the saturation was only 89, 90%, 91%. Then that was acceptable, because as per the guidelines it says that you're not trying to make it normalize, you're trying to like manage, you have to accept the minimum standards. That's what they say. So saturation of like 80, 89, 90, 91, that was acceptable for us. And repeated blood gas showed improvement in oxygenation with a normal pH, progressively, as I say. This was an X-ray after maybe, I think, after 2 days of intubation. I'm sorry. This X-ray was taken on 11th of March. As I said, she was intubated on 10th, because she was admitted on 9th, as I have mentioned already in the previous slide. So this X-ray was taken on 11th of March, which is like 2 days after the previous X-ray, which I have shown initially. So you could see how it had worsened. You could appreciate the air bronchograms here. It looks like a classic presentation of ARDS. There was patchy infiltrates. It was like, you, as we say, it's like a full blown ARDS already. And she was ventilated. Yeah. So what all precautions did we take? Like, as I said, we are already in a high PEEP, like 14 PEEP, and FiO2 was 100%, and then but gradually we were able to come down like up to 70% with a PEEP of 14. And the precautions what we had taken in order to maintain the saturation, and in order to maintain the lung, in order to protect the lung, basically closed suction was connected. It's a must for all patients here that we use a closed suction during ventilation, because we know that less disconnection. We don't want to disconnect every now and then for suction, or it's like you are losing the PEEP basically. So we had used a closed section. The clamping of endotracheal tube was done in case of disconnection from the ventilator. So in case if we had to disconnect the patient from for any purpose or anything, like maybe if the HME was soiled or something like that, we used to clamp the endotracheal tube, and then we used to disconnect so that we can maintain the PEEP. The HME filters used in both patient and ventilator side. So we had, since after all this is an infected patient, so we had used a bacterial filter in the ventilator end also, so that we could prevent the ventilator as well, because after all we have to use this machine for other patients also. So we have been using this bacterial filters in the ventilator side, and HME filters was obviously used for the patient side. So we were not using any kind of active humidifiers here. It was just HME filters, and that was changed every 5 to 7 days. So we were changing like every 7th day. We used to change it, or unless it was found to be soiled. But in this case, in her case, in this patient's case, we have not changed it. Like just every 7 days only, we used to change it. The ventilation strategies what we have followed, it is completely related to what is ARDS protocol. So we have used to do recruitment with incremental PEEP strategies was performed. It is said that we could also use PEEP as in recruitment maneuver in the meaning, in the meaning we can even increase I mean, we can keep on CPAP and then increase the PEEP to 20 and ventilate. And actually, I think in some of the institutions they are not practicing this incremental PEEP, but however we had tried the incremental PEEP strategy here. That was actually, if I should say it, we just tried it once only, but by the time patient was already fine. And we obviously followed the low ventilation strategy. We were trying to achieve only 4 to 6 ml per kg. So her if I could say, her weight was around 75, and we made a tidal volume of around 380, if I could remember. Yes, we had a tidal volume of 380. So we had followed that strategy basically. So the day 7 was the day when, so all these during this all these processes, we are not saying that we are only the ones, I mean, or the ventilators are the one who's doing the job. No, it's not like that. The pharmacological therapies, like the appropriate kind of medicines, that, as they say, they're hydrochloroquinones, and all sorts of other along with that, the other antibiotics also they were giving for the lungs and for the active infection. For all these processes, finally it yield good actually, and because we had given a sedation vacation, and in between we gave a weaning trial also. So finally we found that the patient was getting better. We gave a sedation vacation every day, and we tried on spontaneous mode as part of weaning trial for like almost we have given like alternative, maybe like 3 hours on spontaneous, and on SIMV we had given alternating trials. And then finally, we got a chance to extubate the patient on seventh day. So she was extubated and she was put onto non-rebreathing mask of 15 liters of oxygen. She was stable throughout the ICU days. I will repeat it again because she was not on any inotropes or anything. It was just the lungs that had affected her. Later, she was shifted. We weaned her oxygen. Now currently she's on room air. She is still in our ward, in our isolation ward. She is just on room air. Her X-ray is good. Um, she's better actually. So if you could see the X-ray now, this is her current X-ray. If this was just taken recently, just 2 days back only, this X-ray was there, and this is the X-ray which you could see maybe when she was intubated, and it was very bad. So you could see the difference here. How much the lungs had played. I mean, how the ventilator played their role, and of course their other pharmacological therapies. So this is a case of this young patient, which I would like to say, who doesn't have any comorbid conditions and who was perfectly fine. So, moving on to next case. This is a 70-year-old patient. He is actually he had a travel history. He was traveling. He was a transit patient, and he is also a known case of hypertension and diabetes mellitus. He was already having a cough, and he was having fever with tachypnea, usage, labored breathing, and then he had gone to another hospital in one of the private hospitals, and he was diagnosed as COVID positive from there. Then later, for further management, he was brought here to our hospital. So initially, when he came itself, we had started him on 15 liters of high concentration mask because he was severely hypoxemic, and he was very distressed. Sorry. So he was electively intubated. So now, as he is already a confirmed case of COVID, we had used the same kind of PPE guidelines as per the guidelines, the hazmat suit, the gown, and everything. About like we all the members who were attending the intubation, they were using all the kind of PPE measures. So his intubation also was uneventful. It was a rapid sequence intubation with adequately sedating and paralyzing the patient. The initial ventilator settings for him, it was on pressure control mode with a pressure control. We had to titrate it between 12 to 18 centimeters of water with ideal tidal volume of like 4 to 6 ml per kg, and PEEP was 8. Because we initiated with a PEEP of 8, we thought that we could titrate it later, and a rate of 14. ABG showed severe hypoxemia with a PF ratio of 90. This ABG was done actually post intubation, I have to say. So he was hemodynamically unstable also. So the decision of intubation was quite fast in this case. He was, due to the unstable BP, he was started on low dose inotropic support with an ORAD of 0.04 max per kg in order to achieve the target map. So continuous infusion of neuromuscular blockades along with the sedation was started with fentanyl and Imbex. Everything was going on a continuous basis. A continuous infusion was made. He was febrile continuously, and urine output was low, which was managed with the Lasix. He developed acute kidney injury with because his renal profile was deranged later with hypernatremia and hyperchloremia, and he was having also hypokalemia. So this was managed with and corrected with pharmacological therapies and fluid management. On the day 6, he was extubated successfully, I have to say, because we were still giving successful in between. Though we had corrected the renal profile and everything, within 2 days of ventilation, we could switch off the inotropic support. The later it was after the inotropic support was completely switched off, we had started with the weaning sessions. sedation vacation was done. So we got a chance to extubate him. And he was put on 15 liters of oxygen with a non-rebreathing mask. He was hemodynamically stable throughout the ICU days with the support of low flow oxygen therapy. Right now also the patient is still there, but he is just on a low flow oxygen therapy, that is nasal cannula of just 4 liters. He was again shifted to isolation ward for further care. It was fine for him. So I would like to show you the X-ray. I did not show you initially because the X-ray during his admission, and then it was like because he had already taken one X-ray from the previous hospital. From as soon as he came here, the decision of intubation was quite fast. So after intubation only, due to several reasons, we could take an X-ray. So this was his X-ray after just soon after the intubation. So you could see how worse it was. I'm sorry. and yeah, this is his present X-ray, which he was extubated. He's almost this was his thing just yesterday. This X-ray was taken yesterday. It has a small paraneumonic effusion here, but still he's fine. He is like clinically he's fine, and his latest report for COVID was found to be negative also. I did not mention for her also. For her also, the COVID the latest report was found to be negative. So she was fine. So uh, what actually I just want to deliver from my presentations is just that these are some of the main points I would like to discuss. So adults with severe COVID who's in distress, if they have an initially saturation maybe like 94%, 88 to 94%, that was a standard one. And they say once stable, more than 90% is fine as per the WHO guidelines. So there is a controversy, like if you can use the high flow nasal cannula or NIV in these kind of patients. Actually, the problem with this is more comfortable for the patient probably, but it's the main issue is the exposure, because they say that it's the like environmental contamination. So this is not really recommended in the current setting. We are not really because the more of airborne and I mean droplet exposure is higher in NIV, because every now and then you disconnect it, you connect it again, and high flow nasal cannula also, there is a high chance of exposure there also. So it's not really recommended. So it's like they initially you will start with a nasal cannula or high concentration mask, and that's how you proceed. And you, even if you start with an NIV or high flow nasal cannula, the decision of intubation should not be delayed. That's what they say. So do not delay intubation. The primary goal is for us is to support the lungs until the virus has passed. So prioritize the lung protective strategies with minimum acceptable standards. That's what I said. We are not aiming for a perfect or a perfect oxygen or a perfect PCO2, anything like that. We are just accepting. We have to accept the fact that there should be a minimum acceptable standards instead of normalizing. Sorry. Use in ventilation strategies, the use of PEEP was actually more important in these cases. What we have seen so far, the we had initiated with a PEEP of 10 and 8 for both of the patients, which I have mentioned already. This PEEP were later we had to titrate it up to 14 for both the patients. The For the elderly man as well, we had to titrate it up to 14. There was luckily there was no much of hypotension in the elderly man, and for the young lady she was fine. For the hypertension, we had to maintain it with the NORAD support also for the elderly man, as I have already said. So basically the use of you have to use the PEEP like in a proper way, so that you can really achieve the oxygenation. You can control the hypoxemia more or less with the wise usage of PEEP. And to reach LPV targets, allow permissive hypercapnia. So as per the lung protective ventilation target, we have to allow for permissive hypercapnia. We should not be worried about PCO2 here. It's about the pH and the oxygenation that we are worried right now. And for these patients, it's must that deep sedation or a continuous infusion of neuromuscular blockade is must, because we are using a PEEP of 14 or maybe 12 or 10. Anything above 12, they say anything above 10, here they recommend a continuous infusion of Nimbex or the neuromuscular blockades. So ideally, what we use here is Nimbex with 10 max. Ideally, they give 10 max per kg in an hour, so that they are completely sedated. So that is actually one of the main thing, because we all have encountered in situations where the patient might be awake and then he starts to cough or something, and then the patient will desaturate all these things. So we, just to avoid in this case, we don't want to take a chance in these cases, right? So we keep a infusion of neuromuscular blockade. So we highly recommend that. And proning is also considered in order to improve the oxygenation, though we have not tried proning here so far in any of the COVID patients. But it's said that it could be considered, but the issue is that it requires a high staffing. You need a more number of staff, and as since it is an infected patient, it's a stressful situation for both the staff as well, and even for the even for ourselves and even for the nurses. So it's like you need a more number of people, and they need the risk of exposure is high in if you have to prone, and then you need more a number of people there. So we are not really so far we never got a chance to prone a patient, but even don't know, we don't, maybe later in the stage, we don't know. But as of now, it is also considered as that will improve the oxygenation. And regarding the ABGs, we are not very keen about taking ABGs every now and then. It's just like once in a day we will be taking one ABG, and we'll be connecting ETCO2 monitor, so in order to monitor the carbon dioxide. And of course, for the saturation, we have the for the oxygen, we have the saturation the monitor there. So we are not very keen about taking the ABGs every now and then. Once the pH is fine, like if it is greater than 7.20, then we are good. So the ABGs will be repeated only if there is any changes in the settings made, or if in case of emergency situations only we'll be taking. Otherwise, it's just as a routine, we'll be taking once in a day. And we know that no need to normalize no need to normalize the pH unless I mean, if it is greater than 7.20, it's fine. And minimum acceptable PO2 goal is 60, or higher is fine. So in these patients, we what the trend commonly seen was, even with the FiO2 of 70% and PO14, PO2 was like 70, 75, or maybe it was ranging between 70 to 80, which was acceptable. It was we were not worried about that. After all, saturation was good. Saturation was maintained like 92, 95%. So it was fine. Then closed section technique, as I said before, it was practiced. It's a mandatory actually. And HMEs to be changed every 7 days or before of soil. As I said, HMEs have to be changed only 7 days. We don't have to change it every day, and unless it is because the risk of exposure and the risk of disconnection every now and then, the loss of PEEP, all these things have to be taken care of. So HMEs to be was changed only every seventh day. The conservative fluid management also was done, because we don't want to overload the lungs. So finally we have to, the fluids was managed in such a way that it is yeah, it's not like positive we are not flooding the lungs. And the main thing we have to check is we have to avoid the exposures that increase the that we have to avoid the exposures that increase the exposure. Like you don't have to we have to minimize ourselves for the exposures. That is risk, including truck placement change, bronchoscopies, etc. Unless it is very urgent or some emergency situations only, we are really keen to exploit all these things, like and otherwise we don't have to expose ourselves with the patient. That's what I meant in that. So most importantly, it's the use of PPE. Just protect your patients, protect yourself, protect your family, basically. And and what we all hear these days, it's just hand hygiene, do good, and spread awareness among everyone. I am not sure whether I don't know whether I've really conveyed the message, but I hope I have conveyed some of the topics, just vaguely, uh, and I hope this was quite informative for you. Just that's it.